Thank you, Namrata, for inviting me for this particular course and be part of this team. And I would be talking about viral keratitis and attaining the right balance, because very often we have issues related to diagnosis and then going on to the management. Viral keratitis specifically, it differs from bacterial and fungal keratitis because they are usually chronic, recurrent, they're frequent relapses, unlike bacterial and fungal keratitis, which once resolved stay like that. And initially, it was thought that they are uncommon in the developing countries, but it's not so. They're quite common, and they're painful. They're site-threatening infections. They may be epithelial, but they also have recurring stromal and endothelial components. And they very often have morbidity due to corneal scarring and neovascularization, because of which they affect the quality of life when patients are not experiencing active infections. And the virus usually is latent in the trigeminal ganglion. And this is the way a typical dendritic keratitis which may present. And as we always teach the undergraduates that more symptoms, less signs. So slit lamp examination becomes mandatory. And typically a dendrite looks like this, a branching dendrite with terminal bulbs. And I've just put this picture just to say that a case which came to me, and on treatment, once picked up, on treatment, this is exactly the picture at 48 hours. And this is how the lesion heals properly. And this picture, this is in between. Once, how do we know when the dendrite is healing? You can see that the extent of the dendrite tends to diminish over the period of time. Clinically, it's important to know whether the viruses we are treating with infectious epithelial keratitis, or is it the stromal element which is more, or is it the endothelitis, or it is the uveitis, or it's a keratouveitis, or it's a neurotrophic keratitis. So important to know what element of the cornea is more affected. If it is infectious epithelial keratitis, it may be presenting in the form of a dendrite, or it may be a geographical presentation. If it's stromal, it may be disciform or necrotizing or interstitial keratitis. Then endothelitis, which may be associated with deep stromal keratitis. And it's not uncommon to say only uveitis or keratouveitis and neurotrophic keratitis. Once we know what form of keratitis we are dealing with, the treatment becomes easier. Because when it is epithelial keratitis, we don't use steroids, and it's when the stromal keratitis, the benchmark is steroids. This is a typical geographical ulcer which presents. It may present like this feature, so it's like an amoeboid kind of an ulcer. And as you can see on the slit, there is occurring a defect over here, and underlying cornea is edematous. And so these are the different phases when the healing takes place. Herpetic stromal keratitis, infectious epithelial keratitis, virus is actually multiplying in the epithelium, and that's how the stromal keratitis differ. It's primarily an immune response to the epithelial disease, and very often we see the epithelial keratitis and stromal keratitis coexisting. And it is usually an epithelial response to HSV, which is in the anterior stroma, or which is present in the nerves. It may be non-necrotizing or a necrotizing inflammation. And in non-necrotizing, you usually have an intact epithelium. So when you stain, you will get stain negative. There is a focal or a diffuse multifocal associated with anterior uveitis, which may be typically in the form of a disciform keratitis. And a necrotizing stromal keratitis is invariably in the form of as if we have pus in the cornea, very severe necrosis, there's ulceration, and there is dense infiltration, and eye is very inflamed in those cases. So you may have a difference whether to differentiate whether you are dealing with a bacterial keratitis. And here, HSV DNA may be present, while I've seen few cases of necrotizing keratitis when you get a severe inflammatory response, and it may result in thinning and perforation. So this is what a typical viral stromal, this is the right and the left eye of the patient. And quite often you may mistake, because this was the left eye, patient had been operated for a simple corneal scar. And you can see that there is present a clear graft, operated PK, while the patient was being treated. the right eye presented with this kind of a simple corneal edema, and there are present KPs on the endothelium. And this is when the patient went on to the healing stage, the edema goes down and may leave a simple scar. This is how a necrotizing keratitis presents. When we have some, you may feel as if it's like a pus kind of a thing present in the cornea, and there is present an epithelial defect. It's highly inflamed. Dense stromal infiltration is there. There's ulceration, necrosis, and this is due to direct infection of the corneal stroma with severe host inflammatory reaction. So these are the cases where primary treatment is oral antivirals. We may have a presentation in the form of a deep stromal keratitis, which may amalgamate with endothelitis, where we get these kind of folds in the decimus level, and there is present endothelial edema associated with it and KPs. And a deeper layer of the stroma is affected. It is not associated with any epithelial lesions, so again, it will be stain negative, and they have a prolonged course. And as I told you in the beginning, the bugbear is a recurrence. So recurrent stromal keratitis, we've had cases which present to you at times with edema, and then 2-3 months later, they may come to us with saying that my vision has gone down. I have plenty of these bilateral patients following up with me. And then when you look at the edge, there may be another edge where there will be edema, while another edge where it will be just a simple corneal scar. This is the fellow eye of the same patient, which you can see the slit through different areas, and there is a fusiform edema over there. So this is another patient, which is a recurrent multifocal keratitis. One area is scar, while I've just tried to take the slit through multiple areas just to see that what we are dealing with, because that area which was initially affected has gone into a scarring stage, but there's another area affected with very, very severe edema. And these patients are like usually have 2x60, 3x60 vision. And yeah, Namrata, I will be needing a little bit more time. So when recurrent viral keratitis may present to us with the kind of a dendrite at times, and which may present a dendrite, and it has to be treated. Herpetic endothelitis may present in this form when there is a deep stromal edema, and they, as you can see, they have KPs, which we see on the indirect illumination, whether it is an immunological reaction to virus or it is a cytolytic effect of the virus on the endothelium. And we treat them, these patients, by giving oral antiviral, 400 or 800 mg 5 times a day with steroids when they're stain negative, which they are usually. And at times they may go, these endothelitis may lead to a permanent endothelial failure, and they may need endothelial surgeries. There's another patient of mine who had had a multifocal done outside. 1 month down the line, she presented with the diminution of vision. And here you can see that she presented with this kind of a localized edema, and there are present decimus folds. Basically, she had presented with endothelitis post-successful multifocal surgery. This is another presentation of a neurotrophic keratitis when they have decreased corneal sensation and tear production. And the treatment here is only lubricants, patching, tarsorrhaphy, or autologous plasma growth factors. So why I'm highlighting over this again and again, just to know which layer of the cornea is primarily affected, and the treatment is directed according to that. This is a resolved ulcer, and which may leave a thinning over there. The commonest presentation which we have is a combined presentation. So we evaluate, is it the epithelial layer affected, or it is the stromal layer affected, or the both affected. So as long as the patient is stain positive, we do not use topical steroids in these patients. Another not so uncommon condition, when you may operate a phaco on a simple corneal scar, or I've had patients have had glaucoma surgery with corneal scar, and post-op steroids are given, and then there is a flaring of the viral keratitis. They may be secondarily infected with hypopyon. This is another patient of mine who was following up with me for a long time, which presented with a small kind of an infiltration over here. And this is the same patient over the period of time, kept on, did not respond, had an interstitial keratitis, and eventually leading to secondary infection. Though patient was being put on oral antiviral, and I had to do a scraping through that, which just did inflammatory cells. So as far as different studies which have been done, which are herpetic eye disease study 1, which said that topical corticosteroids, it significantly improves the stromal keratitis. Oral acyclovir is beneficial in the early resolution of stromal keratitis when used as an adjunct, and oral acyclovir is beneficial in the treatment of iridocyclitis. And there are certain specific indications of using oral acyclovir, which I will be coming on to that. And in a case which we are following of epithelial keratitis, if you start the patient on oral acyclovir, there is no additional benefit that it prevents stromal keratitis or iritis during the subsequent years. As far as when the recurrence is there, a herpetic eye disease study 2 said that long-term suppressive effect of oral acyclovir, 400 mg BD. We really do not know for how long to use. Some of my patients on lifelong oral acyclovir, but we have to start in case of recurrent. We start them, and as for a year, it definitely reduces the recurrence of HSV, epithelial and stromal keratitis, and it is greatest effect seen in patients with prior stromal keratitis. And the triggers have been known to be the trauma through surgery, injury, or any laser. And in HIV infection, when you have is more than threefold increased risk of developing ocular herpes simplex virus. Other treatment options are topical TFT, topical, of course, ASV already I've told you, and then there is ganciclovir and oral medication. There is valacyclovir, and this is the important slide which I want everybody to see, that the role of systemic antiviral in HEDS is that antivirals are useful in the prevention of recurrent episodes of herpetic stromal keratitis. It has a very slow half-life. I mean, it stays in the system for long. Therefore, oral acyclovir is used 5 times a day. And valacyclovir can be used an alternative to acyclovir because it has a little longer half-life, and this is used TDS. So I've given the equivalent. If you have 800 milligram of acyclovir 5 times a day, it is equivalent to 500 milligram of valacyclovir TDS. In cases when you are on maintenance dose of acyclovir 400 mg BD, it is equivalent to 500 milligram valacyclovir OD, and famciclovir 250 or 500 milligram only TDS can also be given. So these are different permutation and combinations whenever your patient says that they don't want to use the drug for a longer period of time. Another one which we have is the topical ganciclovir. It does not have any extra advantage over using acyclovir, except that this is to be used less often, TDS, and rarely in cases which are resistant to acyclovir, ganciclovir may be of use. Whenever we do a PK in a case of earlier herpetic stromal keratitis, there are higher risk of glaucoma rejection, graft rejection, and disease recurrence. And of course, the role of latency is herpetic latency is the lax, which when they are given, it can reduce the incidence of recurrence. So thank you very much. So ultimately, we need to have a balance when we have to have a diagnosis, what layer is affected, balance as far as topical or systemic antiviral is to be used, balance when topical steroids are to be used. Some of the cases of herpetic uveitis present with simple glaucoma, and you just need anti-glaucoma agent, lubricants, dosage of systemic antiviral, and acyclovir or valacyclovir and surgery. So balance of all these things can lead to a very, very successful and a happy patient. Thank you very much.